Corneal edema is one of the common causes of blurred vision after cataract surgery. Let's quickly understand why it happens, how to recognize it, and most importantly, how to manage it. Now, this image shows a classic example of post-operative corneal edema following cataract surgery. You can appreciate the diffuse corneal haze giving cornea a cloudy appearance. The normal transparency of cornea is lost due to stromal hydration. Also, clinically, patients present with blurred vision, glare, halos, and sometimes discomfort if epithelial bullae are present. Let's discuss the usual suspects with major causes of early post-operative corneal edema. Firstly, surgical effects. They are most common causes. During phacoemulsification, mechanical energy and ultrasound can directly damage the endothelial cells. In addition, instrument manipulation within the anterior chamber and retained lens fragments or prolonged surgical time can all increase endothelial stress and lead to edema. Then endothelial diseases. Some patients already have compromised endothelium before surgery. For example, Fuchs endothelial dystrophy. It is a key risk factor. Similarly, patients with low endothelial cell density are more vulnerable. We can also see edema due to decimate membrane detachment, which disrupts the endothelial functions. Lastly, toxic effects. These are often preventable causes. One important condition is toxic anterior segment syndrome, which results from intraocular inflammation due to contaminants, which include preservatives in intraocular solutions, incorrect concentration of irrigating fluids, or residual toxic substances on surgical instruments. Finally, elevated intraocular pressure and increase in the IOP after surgery can impair endothelial pump function, leading to fluid accumulation in the cornea. So overall, early corneal edema is usually multifactorial, and identifying the underlying cause is crucial for targeted management and better visual outcomes. Now, coming to the late causes of edema, which is usually due to chronic damage, including IOL related issues like endothelial touch or UGH syndrome, or persistent endothelial contact, retained lens fragments or debris, or rare conditions like Brown-McLean syndrome. This image shows decimate membrane detachment, a cause of postoperative corneal edema. On the left, you can see the areas of corneal haze, and the arrows highlights the detached decimate membrane, which appears as subtle separation or fold. On the right, the OCT image clearly demonstrates the separation of decimate membrane from the stroma. This disrupts the endothelial function, leading to stromal edema and decreased vision. Now, this image shows Brown-McLean syndrome, which is a late complication after cataract surgery. Notice the peripheral corneal edema, which typically starts inferiorly and progresses circumferentially. Importantly, the central cornea is spared, so vision may remain relatively preserved in early stages. It is usually due to chronic endothelial cell loss, and management is mostly conservative unless complications develop. Uveitis glaucoma hyphema syndrome, a complication of malpositioned intraocular lens. You can see corneal edema associated with inflammation and hyphema. The IOL causes mechanical irritation to the surrounding structures, leading to recurrent inflammation and raised intraocular pressure. Now, how we can prevent corneal edema at different stages of cataract surgery? Firstly, preoperative risk mapping. We assess the cornea before surgery using specular microscopy to check endothelial cell count. If the count is low, we proceed with extra caution. Secondly, intraoperative protection. The goal here is to protect the endothelium during the surgery. We use dispersive viscoelastics to coat and shield the corneal endothelium from ultrasound energy. Also, we minimize phaco energy and effective phaco time, keeping settings efficient and controlled. And importantly, we work in the safe zone, keeping the surgical maneuvers away from the corneal endothelium. Finally, post-operative vigilance. Early detection is key. If the cornea appears hazy on the first post-operative day, we should act early, increase the steroids, and manage promptly rather than waiting. Now, coming to the treatment options for corneal edema. Firstly, hypertonic saline. It works by creating an osmotic gradient, drawing fluid out of the cornea. We use drops during the day for better vision and ointments at night for sustained effect. Then topical steroids, typically prednisolone acetate 1%. It helps in reducing inflammations and protecting remaining endothelial cells. Steroids should be tapered gradually to avoid rebound inflammation or rise in intraocular pressure. Further management includes aqueous suppressants, which help by lowering intraocular pressure and improving endothelial pump function. We should avoid prostaglandin analogs in early postoperative period as they can worsen the inflammation. And if patients develop painful epithelial bullae, a bandage contact lens can provide symptomatic relief by reducing the friction from blinking. And in severe non-resolving cases, the definitive management includes endothelial keratoplasty. Now, in most cases, edema resolves within 4 to 6 weeks, but if it persists, it may indicate permanent endothelial damage. Now, the first image is of a patient with chronic non-resolving corneal edema after cataract surgery, and the second image is after he had undergone DSEK surgery. So, the most important takeaway here is if edema does not resolve within 6 weeks to 3 months, the patient should be referred early for endothelial keratoplasty. Because if you wait too long, it leads to subepithelial fibrosis and stromal scarring, which can permanently limit vision even after a successful endothelial keratoplasty. Recognize early, refer on time. Don't wait for the vision to worsen. Early action can save sight. Thank you.